Okay, so I'm Richard Osborne from Australia, and I'm a professor in global health and equity development, and have had the opportunity to work in many countries and live in several countries in different parts of the world. So today's presentation, it's really focusing on authentic co-design. I'm keen for you. I'm hoping that you will be able to get access to various tools and processes and examples to strengthen your work locally. I'd like to declare I have no conflicts of interest. All the tools I present today are open source on the web, and I'm mainly funded by the Australian government and my university. I'd like to acknowledge that my university is on the land of the Indigenous people of Australia. So indeed, the Latrobe campuses are on the Wurundjeri people, where my campus is, and I'd like to pay my respects to elders past, present and emerging, and to acknowledge that their lands was never ceded and never will be. So by the end of the session, I'm hoping that you'll be able to integrate good practices in co-designing a contextually appropriate plan that integrates local wisdom to improve implementation effectiveness and equity. This is very ambitious, but let's start and try to do this. So first of all, what is authentic co-design? Well, here's a hierarchy that was developed over the years of the different kinds of co-design you might do and the implications of these. At the bottom, we have what some people might call co-design. I probably wouldn't. End users are told what is going to happen or read about it in a report, or worse, they hear about it in the media. So if you're seeking to go to co-design with end users, your stakeholders, and this is what they find out, well, they may or may not be aware, because not many may reach this in a way that they understand. And there may be passive resistance to your work. Actually, some groups may feel threatened. So this is not optimal co-design, not really authentic at all. At the next level, end users are informed after decisions and protocol have been produced, and they're told they're part of a consensus. They may not have experienced that, but that also can lead to risks such as your stakeholders not being aware. There may be passive resistance. They may feel threatened. So often co-design is done like this. It's a rushed process that was active, but not really very inclusive. In a lot of settings, the time and the work that needs to be put in to really engage community authentically, to reach those people who really are the stakeholders who have the greatest capacity to potentially benefit, and the people who are actually seeking to serve. Often time is not allocated and funds are not allocated to do that work, and it really is work. Importantly, if you do co-design like this, at least they may be aware. They may be aware of the work you're doing and the importance of it. A step up from this is end users and implementers experience partnership. They know that their voices were heard, and they're continuously engaged and informed of the research. If this happens, your stakeholders, your end users, may be responsive. They may cooperate with you, and they would certainly be aware if you do this broadly. Ultimately, and this is sometimes very difficult to achieve, that the end users and the implementers mutually convene, mutually co-lead, or lead the process. That your stakeholders are actually leading the work for themselves, for their communities, for their stakeholders. And you, as the facilitator, the researcher, or the program manager, you're there to facilitate and not lead, because this is work by them, for their community. In that sort of setting, you can get vested interest. You can have deep ownership. And there can certainly be advocates for your program to be beyond where you start. And of course, they will be responsive, cooperative, and certainly well aware and actually champions of your work. So this is one way of looking at co-design in the context setting. and the potential implications of different co-design styles. So co-design methods to really hear the soft voices, to really hear the local wisdom, and to authentically use this for intervention co-design. In one of our programs, we set up a way of talking about the situation as, well, every voice is as soft as everyone else's. Often you might have the loudest voices being heard, but to really help enable fair and equitable voices, we have this concept of every voice is as soft as everyone else and is as heard as anyone else's. We were very fortunate to work with the WHO Global Coordinating Mechanism for Non-Communicable Diseases in Geneva to develop health literacy concepts. The global working group worked for several years, and it resulted in this 4-volume report. And a lot of the ideas I present today, or virtually all the ideas, are already in here. In particular, draw attention to a volume of case studies, a little bit outdated, and there's many case studies from different parts of the world. There was the initial case studies, but now this process of Ophelia, which is the community co-design process, which I'll now describe, has really taken off in many, many settings, in small programs and large programs, in low resource settings and in well resource settings. So Ophelia is optimizing health literacy and access. It's a process that uses health literacy thinking to connect people at all levels in a community in co-design, prioritization, and the implementation of locally designed fit-for-purpose solutions. Our work is about doing the maximum amount of good, the minimum amount of money, where there is really tremendous turnaround of taxpayers' money or donors' money into community benefit. And this is the Ophelia manual with a QR code, and all of our thinking for the last 20 years has been put down here for a step-by-step manual. We do recognise that one size doesn't fit all, even though we have a lot of flexible processes. The principles are a really important part of Ophelia because you need to change things given context. So very quickly, the principles include focus on the outcomes, be driven by equity, be driven by local wisdom, go ahead and diagnose local needs, use a co-design approach, be responsive to the local needs, and that may vary, apply your work across systems, and from day one is the first day of ensuring your work is sustainable. I'm going to give you a very quick example of a program we did in Australia with women to improve awareness and participation amongst Aboriginal, Arabic and Italian women in breast cancer screening. And this is one of the case studies in the WHO report, Volume 4. So the aim of this work was to increase screening amongst under-screened groups. And some of the most urgent groups to look at were Arabic-speaking, Italian-speaking, Aboriginal women, and Australian women in various suburbs which had low systemic position. To start the work, we engaged the community members and we went to where they lived, we went to where they worked, and we worked with them to collect data, health literacy questionnaire data, which is a needs assessment, detailed information about the mechanisms by which people can and can't engage with health information services. Here is a photo of our Arabic-speaking advisory group, and we collected substantial data from these groups. We also included a large number of health workers across various areas as well, and they participated in the co-design workshops, which I'll now describe. But here's a unique element of the process which we sometimes use, not always use in our work. But when we collect health literacy data using the health literacy questionnaire, this needs assessment based on people's hearts and minds, it has these 9 dimensions. Healthcare provider support that a person might have. Does the person have sufficient information? Are they able to actively manage their health? Social support for health? Can they appraise health information effectively? Are they able to actively engage with their healthcare professional? Number 7, can they navigate the healthcare system? Can they find good information? And can they understand health information well enough to know what to do? So these are 9 very different dimensions now used in 100 countries to do an analysis where we find out the different subgroups of people in the community. It's actually very much the same as what marketing companies have been doing for decades. So here is line number 7, line C. There's 7 people in this cluster. They all have very similar scores across these 9 dimensions. This particular group, they have fairly high health provider support. The green means high, and the red and the orange means low. They're pretty low and actively managing their health. And you can see there's a pattern here which is distinct from the other groups. And this informs us to develop a vignette, a story about the people. Bit easy here. Oh, oops, jumped ahead of myself. So here's a story based on this health literacy profile and from interviews of people within the cluster, within this group, and feedback from the women themselves. So I only do part of this to give you a flavour. So Basira is age 55 and lives with her husband and 2 children who are in their early 20s. Basira and her husband immigrated to Australia 25 years ago and became citizens soon after that. Basira completed secondary education in her home country and worked part-time in a local shop. Basira firmly believes her family comes first and feels she is lucky to be so healthy herself. Since the menopause, she does sometimes feel quite anxious, but thinks this is normal. She also has asthma, and her GP has put her on an action plan, but she often forgets to take her puffer, her asthma medication, with her when she leaves the house. Scale 3, struggling with self-managing or managing the health. Basira does have a GP who she will see when she gets sick, scale 1 and 6. But otherwise, she doesn't use any other health services, scale 7, navigating the healthcare system. And while she would like information, scale 2, she finds it okay. It satisfies her, scale 8. And she finds it hard to work out if it's useful on appraisal health information. So you can see here's a picture of a person from a community. And we work with the community to have evidence-based, a whole series of vignettes or stories from people in the community. And there's a bit more to the story, but we don't need to go through that just now. I want to share with you the questions we ask of the community members. So we first ask in small groups of 6 to 10, sometimes a bit more. Sometimes these are emailed out, sometimes they're mailed out, sometimes they're done online, sometimes face-to-face. It depends on what community feels safe and comfortable with. So first of all, we try to develop a relationship with the person in the story. So we ask this question: do you recognise this person in your community? And what are their main issues? So we develop an understanding. We discuss this person, their situation. Then we'll ask what strategies could be used to help this individual. And then we'll ask if there are lots of people like this in your community, what could organisations do to improve outcomes for these people? So you see with question 3, we're getting the individual interventions. And number 4, we're seeing system interventions. And we're not asking abstract questions of people like, what are your needs? Or what do you want? People in the community and professionals are seeing real live stories that come from the data. Groups are separate of these, and they come up with many, many ideas. Oops, I've just changed my system here. They come up with hundreds of ideas across perhaps interventions or actions at the individual level, at the family or community level, the health worker level, and the organisation policy level. We get many, many ideas from the community, and these are also the members of the community who will be participating and working with us for the implementation. So the organisation prioritised 7 ideas to start with. They all thought all the ideas were relevant and doable, but as part of a research project, we worked with 7. Outbound calls in their own language, sending invitations in language to participate in screening, a peer education program, information booths in pharmacies, staff training, media advertisements and animation, shawls designed by Aboriginal women. So I'm just going to give 2 of these examples. We knew one didn't work, sending out invitations, but all the others really worked and were implemented in full across the organisation. With the outbound calls, calling a person in their own language, so amongst both the Arabic and Italian women, we found a 10 times increase, not only in just booking, but actually attending. This is then published as a randomized controlled trial. So it's a very low-cost intervention where simply the women said, call us in our own language. We'll listen to you then. And they sure did. In a randomized controlled trial, 10 times increase. One of the other extraordinary programs was with Aboriginal women, and none of my team members are Aboriginal. So we had to be in the background and really to enable the women to co-design in the way they saw fit. Someone had seen in one of the yarning circles, a traditional way of communities coming together and thinking and talking together, had seen an idea in New Zealand where women wrap themselves in a shawl or a cloak. So what happened with this is that rather than none or one woman turning up in the community to attend screening, they designed their own shawls over months together and then came as a community to take part in the health promotion opportunities. They said they wouldn't take part in screening because they didn't feel culturally safe, but when they made their own screening specific shawls, they came as a community. And this started in Melbourne, got rolled out across the state, and it's such an obviously good idea, and it's very popular with our Minister for Health and other ministries. It's been rolled out and put into practice, also with other cancers and other screening in other states. There's an example in their own documentary. You don't see my name, you don't see any of my team's name, you see no university's name there. This was work done by the Aboriginal community for themselves, by themselves, and we had to get out of their road to do this work. And this is using the 3 phases of Ophelia. I haven't really introduced Ophelia very much to you yet, but I'll come back to that. So the lessons here, community ownership is important. Interventions can be simple, low cost, and far-reaching when they're co-designed. You need to create psychological safety and cultural safety in doing the co-design, and not all identified interventions need to be implemented nor will work. So coming back to the WHO report, and there's a really key diagram here I'd like to share with you in this report. I can't go into much detail, of course, because we have limited time, but I'd like to draw your attention to the thinking around health literacy. So health literacy development is influenced by settings and health determinants. Health literacy is developed over time through social practices. Health literacy is put into action. The health literacy actions being accessing, understanding, appraising, remembering, and using health information, and the ways of learning, really important. Through conversation, through the arts, through the written word, through health professionals, mass media, and apps. You need to consider the barriers to putting health literacy into action. And health literacy development needs to occur across levels, from the individual person through to public policy even. And then there's the recommendations for countries to actually take on health literacy development at a local or national level. So just thinking about these 2 areas here, the health literacy actions, the 5 actions and the ways of learning, I want to introduce to you the health literacy learning matrix. So health literacy has 5 main tasks, and very briefly, health literacy, people have different preferred learning styles, and they need to assess different sorts of information at different times. Now, this is foundational biological and disease concepts they need to understand. And for specific health issues, we really need to deliver what to do information, why do information, how to do information. So as we develop, enable people to have access, they need this sort of information to enable them to access. And there's many And then understanding. There's many levels of understanding health information, including no understanding, all the way through to understanding the principles sufficiently to undertake problem solving and even teaching other people. Appraising is more than just judging something as scientific. It includes deciding if the source is trustworthy, deciding if the information itself is trustworthy, resolving conflicts in information, and deciding if it's relevant or even possible for you to do. That's a big ask we have of people. With retrieving information or remembering, there's a lot of knowledge that we want people to have for future use sometime in the future. The person has a stroke, or there is rising flood levels, or animals get sick. They need to be able to know what to do at the right time. And many people need special techniques to help them remember to follow advice. And if we don't support them to do that, many groups will be left behind. Then with applying is really a one-time decision, but a decision that people need to make repeatedly. People need practical knowledge and problem solving. It's really very important to have that practical knowledge and the problem-solving skills that apply. And in many cultures, trial and error decision-making is really important. People don't just do what they're told by a particular authority. They will actually test many different authorities' processes and then work with what their family thinks is good, not necessarily them individually. So this work can be set up to be in a health literacy learning matrix. At the top, I have accessing, understanding, appraising, remembering, applying, we just talked about. But then there's the different ways in which people learn. So people may prefer to learn through printed materials. They like to read. That's how they learn. Other people, they might like to talk with health staff, and that's how they learn. Some people just like to listen to the media, the TV or the radio. Others, it's community conversations. Community conversations are generally profoundly important in all cultures. Then there's the internet, social media, and AI. And then there's the arts and songs and plays. Many people really only learn, particularly different generations and different cultures, through arts is the way that they learn. So we really need to embrace our community co-design with how people prefer to learn and the tasks of actually putting actions into place. So in summary for this, we have how people learn in the health literacy tasks. Daily health literacy skills and abilities are really important to consider by individuals and or by, with or for the people around them. Health literacy and being able to take action is not an individual thing. Really important for communities and societies overall. So I'll skip that and go straight to thank you very much. It's been terrific to talk to you today, and hopefully some of these tools will be useful for you in the future. Thank you.